Awesome. So we're good to go. Okay, so as I said earlier, my name is Stephanie Condon-Oldgrave, and I'm the founder and director of Craig's Cause Pancreatic Cancer Society. We're based in Nova Scotia, Canada, but we are a national charity. So we have volunteers and staff across Canada, along with our board of directors and our scientific committee. We also have Jeff Sujit joining us. He's the executive director of the Canadian Digestive Health Foundation, and Jeff is based in Ottawa, Canada. And as with us, the Canadian Digestive Health Foundation is a charity, a national charity from across Canada. Craig's Cause and the Canadian Digestive Health Foundation were proud partners of a PERT calculator called Digestive. And this presentation will also encompass pancreatic exocrine insufficiency and pancreatic enzyme replacement therapy. We've partnered with the Canadian Digestive Health Foundation to bring a national Canadian campaign, both on PEI and PERT, as well as this Digest This online PERT calculator. Today, specifically, we're talking about pancreatic exocrine insufficiency and PERT, about good nutritional care and how it improves the outcomes and a patient's quality of life. This means that we need to have a firm understanding of what PEI is and how we treat PEI with PERT. Participants are encouraged to ask questions. You know, we like to have these sessions as interactive as possible. So put up your little Zoom hand that can be found at the bottom. And we'll also be giving about every 10 minutes stopping. And please either type your question in the chat box when you think of it, or wait to the 10 minutes where we take a break and take on questions. But, you know, the more interactive and the more questions you ask will probably help other individuals answer their questions as well. So you can put up your Zoom hand, you know, ask your question in the chat box, or just yell out the question when we have those 5-minute breaks after each 10 minutes. This session is being recorded, and we will send the recording out within a week after it's been edited. So all the information you hear, you will have in your emails in about a week. And anyone that wasn't able to make the night tonight, we'll send that out to them as well. I'd also like to take this opportunity to thank our sponsors, Viatris. Without their commitment, a lot of this wouldn't be possible. So they were a big part of how Digest This PERT calculator came to be, as well as the national campaign across Canada. So later, we're doing a little bit of a flip. We're going to start with Helen Brown, RD, and Dr. Amanda Landers, but we're doing a little bit of a flip. So myself and Jeff will introduce the PERT calculator first, and then we'll have Helen and Amanda talk about pancreatic exocrine insufficiency and PERT. Amanda, Dr. Amanda Landers. Oops, sorry, I just lost my screen. Dr. Amanda Landers. Oh, I can't even see my screen. Sorry, just give me 1 second, friends. Is currently a senior clinical lecturer. She loves to teach about other palliative care and is currently leading an Australian research team looking at enzyme replacement therapy in pancreatic cancer. Helen Brown currently works as a community dietitian at the Nurse Maud Hospice Palliative Care Service, Church Christ. Prior to this, Helen was a dietitian working in mental health at the Hill Morton Hospital and in the community. Both of these individuals have extensive knowledge about PEI and PERT, so we're very enthusiastic that they're here to participate in this. Both have presented nationally and internationally, so I know that you'll learn a lot, just as we have working with them in the past few months. And please, as I said, don't hesitate to ask questions. So I'm going to move on, and Jeff, I'm going to get you to tag team with me about the PERT calculator. So Aaron, if you can go to the next screen. And And we created, so I'll get you just to go back one, there you go. So the PERT calculator is a calculator that came about as a result of a national needs assessment that we conducted with the Canadian Digestive Health Foundation. And what the information that we learned is much like the information and all the research that Dr. Amanda Landers and Helen will be presenting. It showed that, over 80% of the patients that were diagnosed with pancreatic cancer were not receiving pancreatic enzyme replacement therapy. So even though a large part of our population of patients had PEI, many of them weren't being treated. It also showed a large portion of the patients that were being treated, in fact, were taking the incorrect dosage. And also from the healthcare sector, we were also hearing that really they felt inexperienced in how to prescribe PERT as well. They weren't really sure of the proper dosage. The other thing that we found is that this was the patient's biggest struggle, is how many pills to take with their meals and snacks, and what did it all mean? Even, how to take their pills throughout their meals. So as a result of this, Jeff and I and our organizations decided to partner with the support of Viatris, and we wanted to create a tool called the PERT calculator, found on Digestive, that would help patients and help the healthcare sector really understand PERT, how to take PERT, and to get the best results with the food and the weight that they were and the fat that they were consuming. Erin, do you want to move to the next screen? And Jeff, did you want to jump in there and start going through some of the slides? We can go back and forth.
Sure. No, I think you explained everything beautifully. I think if you look at this as, similar to kind of a Weight Watchers type of online application, it is a web-based program. It's not an app that you actually download from the App Store, but it works on all of the types of technology you can imagine. Your laptops, your tablets, your smartphones, works just like an app, it basically, the first thing it's going to ask you, obviously, when you do register, is to, well, actually, we forgot one thing. It will first, when you go to digestthis.ca, you will be introduced to a welcome screen, and the welcome screen is going to actually ask you to register. When you actually register, we basically just, it allows you to put in your own kind of profile, and that's really just answering a few questions. We do ask you to put in your email so that we can communicate with you, and we'll get into why that's important. But also it'll make a record of the type of medication you're on, the type of PERT therapy you're using. And from that, we'll be able to move on to the next step, which is after you've registered, you'll get an email. I know it sounds a little convoluted, but it's not. As soon as you register, you'll get an email instantaneously, which will give you a link to this screen. And this is the calculator, and this is the URL, basically, the web page that you'll want to make sure you bookmark, because you'll always want to go back to this. Otherwise, you'll have to register again. But this is the way it starts out. We ask you to indicate your weight in the way of either pounds or kilograms, and then basically indicate the type of PERT prescription you're on, and the dosage that the different dosages that are available for that prescription. And then it basically just continues on to build your meal. And I'll pass it back to you, Stephanie.
Yeah, so it'll also tell you your maximum tablets that you can have at the bottom, the capsules. So if you look at this, the weight is, 150. So we have a lot of information filled in. It's saying, I think at the bottom, I can't see that. It'll tell you your maximum capsules that you have. And then Erin, if you can move the next screen. Erin?
You're on it.
Sorry, I think there might just be a delay or something. I did move it as soon as you asked.
Okay.
Can you see it now?
Yeah. So when you get to the build your meal, this screen is a scroll down. So we'll pull it up after we go through the slides with you. But the screen, all your meals are on one screen. So we've certainly gone through, we had a soft start with this. We took a lot of feedback from participants and we made it better. But we're still always collecting feedback from participants. So the more people that register for this and use it and can give us feedback, the better we can continue to make it. But it'll have all your different meals or your snack. So the portion of your meal or the whatever you're having for your snack, it's a scroll down. So you just click everything that you're having, how it's cooked, the amount that you're having. And then if you go to the next screen, Erin, then it's going to tell you how many units that are needed for the meal that you described. We did, there won't always be an exact science. However, we have rounded up. So you won't get less, you might get a little bit more, but it's nothing, it won't cause any issues with that. So it tells you the recommended capsules. So if you go through, it's asking you at the bottom to remember your maximum number. Erin, is there one more screen after that? Yes. So then when you're done, so you put in your meal, it's told you, the calculator has told you how many capsules to have with your meal or your snack. This is a really good part of your screen to really attend to as well, because you can begin a new meal. You can recommend new food items. So this calculator is starting to be used really around the world. And some organizations will certainly adapt it into their own language, and also new foods. So this is really important for you to recommend foods that may not be on the list. Also, if you click on PERT tips, it will also give you a variety of tips that have been created by Poppy Kasvis. She's world renowned in her work with PERT and nutrition and PEI, patients with PEI. So she's got a lot of great tips in there. And at the very bottom, if you've had any issues, you can click on that here, and those issues will come to us. And be truthful. Give us the hard information, because without your feedback, we can't continue to improve on this. We've gotten a lot of great feedback from it. It was approved in Canada by Health Canada. And we just got issued our new license. We have to license it every year. So that's exciting for us to have that seal of approval from Health Canada as well. I think that's it. And I saw a couple of questions. So I'm just, Erin, if you want to just bring up the digestthis.ca on your screen, just so I can show them what it looks like. And here it is. So you're just going to register on that button that Erin is pointing to. So as Jeff said, you'll have a registration form. We are asking that you insert your emails, because it's really important for us to have the contact information with you. If we ever had to reach out to registrants and say this was corrected or we had to change this, the diagnosis is also important, as is to give us an idea of who's registering. It's important for us to know who's registering, because it's also really important to know if we're missing a population of people that we have to do a little bit better getting this tool out to. So that is it in a nutshell. I'm going to take about 5 minutes of questions. And I did see, so how do you fill out the lipase based on weight field? That was a question. Do you want to expand on that?
I think she just meant the where it says like your lipase units that you can have for the day.
Okay, so I don't know. I'm hoping I'm going to answer this for you, Catherine, but you can fill out your weight in either pounds or kilograms. and you put it right under, it says your weight. So you put in your weight down there, and then also tell what prescription you currently have. And as you put in the food, as you build your meal, it will tell you how many capsules to have on your meal based on your weight, based on your prescription, and based on the fat content in your meal. So you register, you get an email, save that email because it's going to have your URL that takes you to this calculator. Once you've registered, your weight does fluctuate, so you are changing your weight whenever it's necessary, but you don't have to re-register every time. Just save that URL link that you get in your email. You can use this. Some people learn about their meal and they never have to use it again for that specific meal. It's a great opportunity to really, try different food options out as you're going through the journey. Yes, and I think Jeff just got that question. It's based on weight, and it would also be based on the food content that you're putting in when you prepare your meal. If a person eats a high carb, low fat meal and takes Creon, will it underestimate the dose? Jeff, are you able to handle? Oh, Jeff just said, Jeff actually answered it. It says it shouldn't. The calculator will establish the number of lipase you require to digest your meal based on the items that you select. And we have a mom of a kid who takes enzymes for cystic fibrosis. Can we use this tool for kids too? And yes, Jeff and I had spoken about that, and you are able to use it because it's based on weight. How does it determine the total recommended pills per day? So it recommends the total pills per day because you're putting in the capsules, like your prescription, into the tool, into the calculator. It's also using your weight, and it's taking into account the food that you're putting into your body, so the fat. So when it has your prescription, your weight, and the food, it's able to calculate through the back end the pills that you take per day. So you'll see how many you have left from how many you took with that meal. Can you overdose on Creon? I'm actually going to leave that question up to Helen and Dr. Landers because they're going to be talking about that. So the best thing about Creon is really there's no danger of that happening. But I think what I'm going to do is introduce, so Erin, if you can move the slides, I'm going to introduce both Dr. Landers. I see her there, so that's fantastic. And also Helen Brown. So Dr. Landers, who I mentioned earlier, is a senior clinical lecturer. She has been talking nationally and internationally and looking at PERT and PEI. I think Dr. Landers said since 2014 or 10, maybe 2010. She just commenced a PhD looking at end-stage chronic lung disease and their healthcare network with long-term goal of evaluating a model of care. She also works with a group who strives towards the best practices for those diagnosed with pancreatic cancer in Australasia. And we also have Helen Brown. So next slide. And Helen Brown currently works as a community dietitian at the Nurse Maud Hospital Palliative Care Service by Christchurch. Prior to this, Helen was a dietitian working in mental health and also in the community. She has particular interest in patients with pancreatic cancer, but is also involved in tons of research in this area. She's presented at conferences, as well as Dr. Landers, both nationally and internationally. So we're excited to have them join us. I see some questions popping up, so I'm going to let them start. But every 10 minutes, we're going to have a few questions before you move on, and we'll make sure that all of you have all your questions answered before the end of the session. So welcome, Dr. Landers and Helen, and I will turn the screen over to you.
Hello, everyone. Tēnā koutou katoa, which is hello in our national language. Thank you so much for having us. We're quite privileged and blessed to be talking to you in Canada. It's quite amazing to think of the size of your country versus the size of ours. So we hope that you get something out of what we have to talk about today. And I guess the first thing that I want to mention is we talk about pancreatic exocrine insufficiency, PEI, very long word, which doesn't mean a lot to most people. And it certainly doesn't appear to mean a lot to many clinicians, unfortunately. And so we've taken to calling this pancreatic failure just to put it in line with lung failure and heart failure and make it just as important that clinicians think about the pancreas and the problems that people have with the pancreas, just as they think about the problems people have with their heart and their lungs. It's just as important in our minds. So next slide. So just a little bit about where the pancreas is in the body. I know my son told me he thought it was in the pelvis. So it's sort of like a fish-shaped organ. It's about the size of your standard fish fillet, and it lies on the spine. So it's very much back in the abdomen. And so if you're lying on the floor on your back, it's really lying over your spine, which is why a lot of people with illnesses of the pancreas get back pain, because it's lying very close to the spinal nerves and causes a lot of problems. There's lots of nerves in that area. So you can see it's sort of tucked up at the top of all of your intestines, but lies quite back in the abdomen. It consists of 3 parts. It has a head, a body, and a tail, much like a fish. So it's quite a good analogy. And the head you can see in the picture there is tucked in to the duodenum, or the upper part of all of your intestines, because that's where it tends to work. So that's quite important. So you hopefully now have a visual image of where this organ is in your body and what it's lying next to. Next slide. And it has 2 major functions. It pumps out enzymes, which we've already been hearing about today, that are important in breaking down the protein, the fat, and the carbohydrates in your food. And so it has these little enzymes that go along and kind of mush it up inside your intestines. It also pumps out hormones that are involved in other pathways in the body. But the one that we're really talking about today is the one that's to do with digestion and enzymes. Next slide. So we're going to talk a bit about pancreatic cancer, just to put it all into context. And when we talk about pancreatic cancer, it's not just of the fish-shaped organ that we've been talking about. It could also be the ducts. There's like little pipes or ducts that come out of the organ that feed into the intestines. So there can be cancers in kind of any of those parts, but they produce the same issues around enzymes and digestion. So it doesn't matter in a way where in the pancreas or the ducts it's still all called kind of pancreatic cancer. Next slide. And we looked up some of your Canadian statistics because that's what's relevant to you. And you can see there the numbers. Almost 7,000 Canadians in 2020 were diagnosed with pancreatic cancer. And unfortunately, the prognosis is not good. And that's globally. So a lot of people will die from pancreatic cancer. And you can see in Canada, it's slightly more men than women, but across the world, it tends to be about 50-50. It's not a cancer that tends to be in a particular gender. And the age group we found the most common in is that sort of 6th and 7th decade. So your 60s and 70s, that's the most common age bracket. Next slide. And here's some of your resources. Some very nice person put these in for us. Craig's Cause, who's sponsoring this talk, the Canadian Digest Health Foundation, who's also sponsoring this talk, and the Canadian Cancer Society, which I did look at in preparation for today. Next slide. So from diagnosis, it's quite important to talk with your oncologist or your surgeon about where in the pancreas or in the ducts, the pipes, your cancer's sitting, because that tells you the possibility of digestion problems. So what I mean is, if your cancer's in the head of the pancreas, you can see that it's very close to where all the ducts and pipes are. And so you're much more likely to be having problems with digestion, or what we call malabsorbing. You're not absorbing your food particularly well because the enzymes aren't getting to the right place. Your tumor could be in the body. The most common place is the head of the pancreas, but a smaller number are in the body, and an even smaller number are in the tail. Now, you might think, well, I probably am not malabsorbing if my cancer is in the tail, and it is less likely, but we can't always see the scarring that might be occurring from the cancer itself. Or if you've had pancreatitis, the pancreas might actually be quite scarred anyway. And so we would not say you've got tail of pancreas, therefore you're not malabsorbing. It would really be a clinical decision and maybe even a trial of therapy to see if symptoms improve, or you do your weight stabilizes. So head of pancreas, very likely to be malabsorbing. Body of pancreas, likely but less likely. Tail, less likely but still worth a good assessment. Next slide. So this is sort of unique to pancreatic cancer, and I think this is why sometimes it doesn't get thought about. People think cancer, they think chemotherapy, surgery, radiotherapy, and nutrition and digestion kind of ends up being kind of left at the end a little bit. But pancreatic cancer is unique because it has such a high degree of weight loss. And if you've got head of pancreas cancer, it's 80 to 90% of the time you're malabsorbing. And certainly with the Whipples, and Helen's going to talk about a Whipples a little bit later. So this is a very likely diagnosis for you. Next slide. What's malabsorption?
Okay, so malabsorption from the pancreas is when it's not working. And it can be not working because you've had a Whipple's procedure, so you've had a major part of that fish-like organ removed, so you may not be producing the enzymes. There may be a blockage in the ducts, as Amanda was talking about before, or in the biliary duct, preventing the enzymes actually getting to where they need to be effective. Or the tumour may have knocked out the cells that actually produce the digestive enzymes, so you're not even actually managing to make the enzymes. And the common result is steatorrhea or fatty bowel motions, and definitely weight loss. Now, in our practice, we don't see steatorrhea quite as often as a frontline symptom these days, because we're getting onto patients so much quicker. And also some of our patients are on medications that will tend to constipate. So I don't always look for steatorrhea, but certainly looking for the package of symptoms that will tell me a patient is malabsorbing. Next slide. So if we're looking at the symptoms of malabsorption, what should you be looking for to know whether you might be malabsorbing, so that you can report these to your GP or oncologist or nurse? You may have pain in the abdomen, and classically for women, something I find is they've got discomfort right on the bra line. And it may be that by the end of the day, they're having to take a bra off or wear more comfortable clothing because it is just so uncomfortable. For men, sometimes, particularly if they've had a cardiac history, they feel like somebody's tightening a strap across their chest, and can sometimes confuse it as a cardiac type symptom. And the thing with these symptoms is you may get up first thing in the morning and eat a pretty normal stock standard breakfast every morning and feel quite okay. But progressively as the day goes by and you eat more, your symptoms exacerbate. So by the time you get to the end of the day, you're really uncomfortable. You don't feel like eating that evening meal. You put yourself to bed and you can't get comfortable. So that discomfort can escalate as the day goes by. Indigestion can be a problem, or heartburn. And often I'll ask patients, are you belching more? And often the patient won't know, but family members will nod and say, yes, absolutely they are. And you're belching because you've got undigested food in the bowel. Foul smelling bowel motions, and it's a distinctly different odor to a normal bowel motion. So people really do pick up on that change in odor. And the bowel motion may float. Now, when I first go and see a patient, they may not even be aware what's happening with their bowel motions because they may not actually even check. So it's really important if you're malabsorbing and on PERT that you get used to checking your bowel motions, because that will be an indicator, a quick indicator whether you're taking enough medication or not. If the bowel motion is floating, it means that the fat that you normally would be absorbing to use as energy isn't getting absorbed. It's going through as waste. It makes the bowel motion pale and makes it float. Bloating and fullness, and then nausea and or vomiting. And you may be on a range of anti-nausea medications and still be nauseated because you're malabsorbing. And all of those things can lead to weight loss, negative impact on physical and psychological health, definitely impacts on your quality of life. Next slide.
Yeah, sorry, Helen, we're just at the 10-minute mark. I don't know if you want a minute for a question. Sorry.
Okay.
No, I saw the question there, and we will be answering it soon. That's the Nexium question. So that's the omeprazole that Helen will mention soon. And yes, we definitely think they're a really good combination. So Helen will explain that a little bit more. Just trying to look at the
Any other questions, friends, before we move on? You can put up your hand or just yell out.
Yeah, it almost sounds like you're not managing to digest that food down.
I do wonder if you need quite a long course of the Nexium or the proton pump inhibitor, omeprazole. You've got pantoprazole to try and heal the lining of your gut, your stomach as much as possible. Trialing some Creon after that. And so talk with your oncologist. Sounds like they need to try and heal your stomach as much as possible, and then have a trial of Creon.
Okay. So what can we do for malabsorption with people with pancreatic cancer? Next slide. Okay, so Amanda managed to get this information on what products are available in Canada. And the most common being Creon 25,000 and Creon 10,000. And that is what we are using in New Zealand. The 25,000 just means how many international units of lipase in the capsule. And the 10,000 is 10,000 international units of lipase in the capsule. And generally, if we get your dose of lipase right, the dose of amylase and protease will be right, because it's the lack of lipase that is causing a lot of the symptoms that you suffer with malabsorption. Next slide. Now, it's useful just to know that the digestive enzyme medications that are available are porcine based, which means it's pig based, and our cells and pig cells are quite similar. And as I mentioned before, the dose is determined by the amount of fat in your meal. It's also quite important to note that if you have a sulfur drug allergy, Creon has sulfur as a byproduct of production. So you need to just be mindful of that. Now, in New Zealand, we had another digestive enzyme available called Pancreatic, but unfortunately that has been pulled from the market, and that didn't have Creon as sulfur as a byproduct of production. I've spoken to the Viatris reps, medical supports here in New Zealand, and said, if I have a patient with a sulfur drug allergy, can we just open the capsule, because it's the capsule, not the beads, that have got the sulfur as the byproduct. Can I just get them to open the beads, the capsule, and use the beads? And I've been told, no, that's not recommended, because you can still get some cross-contamination. So if, I'm not sure in Canada, if you have a pancreatic replacement therapy that doesn't have sulfur in it, that you could switch over to, but it is something that is worthwhile keeping in mind. Next slide. So this was just some results from Amanda and my initial research study we did back in 2010. And we did a retrospective audit to just see how well people were being treated with PERT who had pancreatic cancer, and whether it was being prescribed, and then for those that were being prescribed it, was it in the right dose to start with, or were they taking it at the right times? And we found that only 21% of patients, of the patients that we audited, were actually prescribed PERT. And of those 21%, often the dose wasn't right anyway. So as Amanda mentioned right back at the beginning, it's not a condition that's being well managed throughout the world. So by all of us getting together and pushing for it, hopefully we will increase the effective treatment of it. Next slide. And of those people that we found, we looked at what symptoms they were exhibiting. 86% had abdominal pain, 18% wind, 19% bloating, and 24% had diarrhea, which we now know is more likely to be steatorrhea. So you can see that a cluster of symptoms like that will have a real negative impact on your quality of life. Next slide. So if we're looking at guidelines for taking pancreatic enzymes, as has been reiterated several times already in this presentation, it's really important that you take it with every meal and snack. And initially, when we first started looking at patients taking PERT, often they were prescribed it and told to take it with meals, but there was no mention of snacks. So it's really important that you take it for both, otherwise you become symptomatic in between. Some foods don't require creon, so it's your fruits, your tinned fruits, fresh fruits, jellies, fizzy drinks, cordials, fruit juices, your normal cup of tea and coffee that you would have at home that just have a splash of milk in it. There's only a very small amount of protein there, so you don't need to take PERT with that. However, if you are looking at having a latte or a cappuccino or a mainly milky drink, you do need to take some creon with that so that you can digest it. Next slide. If somebody's eating a large meal or they're a slow eater, we tend to recommend splitting the dose, because the most effective time after taking your creon is the first half hour, and then the concentration of it decreases over the 2 to 3 hours you digest your meal. So that first half hour is really important, and it's really important that you take it as you take your first bite of your meal. If you slip into the habit with your other medications of taking it half an hour before a meal, you're knocking out that most important time of the medication. Don't crush or chew the medication, because you'll irritate the inside of your mouth. Now, for people, I often get phone calls from residential care facilities or aged care facilities where patients are on creon, but they can no longer take capsules. You can open the capsule, but put it into an acidic food like jam or pureed vegetables or pureed fruit. And that just means that it keeps the protective coating of the enzymes intact until they get to the duodenum. Because if you put it into a milky-based solution, the protective coating will wear off in your mouth, and by the time it hits the stomach, it knocks out the enzymes, so they're no longer effective. Now, the other thing I say to my patients is in New Zealand, patients who have a struggle remembering to take medication can get them put into blister packs by their pharmacy. So they can just take off a bubble at breakfast time and that's the medication they need to take then. With Creon, I tend to suggest to patients they don't get the Creon put into their blister pack, because if they take a blister off and a family member picks them up at lunchtime, so take them to the mall for half an hour and they take their medication while they're there, and then they come back and half an hour later have their meal, the most effective time of your Creon has gone. However, if a patient really struggles to remember to take the Creon because it's out separately, it's better to have it in the blister pack so that they're at least taking it. And there's a better chance of them getting an effect from it. Now, the other thing I say to patients is sometimes when I first see a patient, they're not taking a laxative because they haven't needed to, because they're malabsorbing, so their bowel motions tend to be softer. And while we know that Creon doesn't constipate, it corrects digestion. So previously your bowels were soft, and so you didn't need to take a laxative. But if you start taking a laxative and it corrects your digestion, you will need to start taking your laxative regime. Otherwise, you will become constipated. And then there's another problem to have to deal with.
So Helen, if we just come back to Dana's question. So for people who can't have big meals, but only have little kind of grazing type meals, what would you suggest?
So in actual fact, for most of my patients, smaller meals more often actually suits better because we can actually get the dose of Creon closer to what the pancreas would be doing itself. So what I tend to do with patients is initially we start them off, if they're eating a smallish sort of meal, I would start them off on 2 25,000s with a meal, one with a snack. And then as you start getting the effect of your Creon and you're feeling better, your appetite may pick up. And so I say to patients, be aware that if your appetite picks up, you will need to increase your dose of Creon, otherwise you will become symptomatic again. Further through our presentation, it shows us how to work out our maximum dose. And then if you know your maximum dose for the day, it gives you confidence yourself to manipulate your dose depending on what you're eating. So for instance, if you were having a small meal in the evening and you would normally take 2 Creon, but all of a sudden family's coming around and you decide to have takeaways, fish and chips or a pizza or something, and we know that's a higher fat meal, or you go out to a restaurant so you don't know what's in the food, I would recommend taking your Creon up 1 capsule or 2 capsules if it's extremely high fat. And that way you will cover yourself for that increased fat in that meal.
And just, are there any enzymes options for Muslim vegan populations? Because they're all pig-based.
Yes, what we generally find is that if we let the patient know that it's a porcine or pig-based medication, they can go to speak to their imam, and usually because it's for a health benefit, they will get exemption for using the product because it's for a health need.
Vegan?
Vegan, I'm sorry, we don't at this stage. I mean, there's research going on all the time to try and work out an artificial form of PERT, but at this stage, there isn't, I'm sorry.
Okay. Is there any other questions while we're just paused there? Okay, we'll keep going. Thank you.
Next slide. Okay, so this is a slide I was talking about, and this is what your calculator is doing for you. And because we haven't had access to the calculator up until now, I always sit down with my patients, find out what their weight is, and I work out their maximum dose for them. Because for a lot of our patients, they're on medications that they have to be very careful about cutting back the dose or increasing the dose because of toxicity. Creon is a very safe medication, and there are few side effects. I very seldom find side effects with patients. However, it's really helpful to give somebody their maximum dose because it gives them confidence then to be able to manipulate their dose themselves and take control back over managing their own health. So that's how I do with my patients. I work out what their weight is, And if they gain some weight, we can then reconfigure it to find out if the amount has gone up. But I also say to patients, I don't anticipate they will ever need to take their maximum dose. That's a lot of capsules, and they're often already on quite a few medications. So it's really just to give them confidence that you can manipulate your dose up and increase it up depending on what you're eating and be quite safe.
We
Next
also
slide.
found with the calculator, I'll just jump in there with the online calculator, the PERT calculator, when it shows you the maximum capsules that you can have through the day, it shows that quite often patients may not use all the capsules. So one of the questions back there is, can you overdose? And there's really no, I think it would almost be impossible to overdose. So
Most of our oncologists and surgeons within pancreatic cancer say you can't overdose, because to get up to 26 to 34 capsules a day, gosh, you're just about having a meal in capsules, aren't you?
Yes,
So,
exactly. So
yeah,
like you're suggesting, the PERT calculator also has erred on the side of rounding up.
yes,
But I think, as you said, as patients become familiar with their meals and their bodies, things will change over time, and they have a
yeah.
little bit of leeway to play there. Sorry, carry
You're
on.
almost better to round up and go slightly a little bit more than underdose and be symptomatic. Next slide.
Okay, so just a little bit of a whiz through of some of the research we've done. I'm just aware of the time. We weren't really in a position to be able to do a big sort of randomized controlled trial. So we did a much lower scale, gave people some questionnaires to do before we gave them PERT, and then the same questionnaires after, when we'd given them kind of best practice PERT. And these are some of the things that we looked at. We wanted to look at quality of life and weight and nutritional assessment. Next slide. It was pretty hard to get patients through the study period. It's one of the challenges doing studies on people with pancreatic cancer and in the palliative care setting. So we did manage to get 29 people through, and everyone said yes. So that was an amazing thing. Everyone wanted to participate, but it was quite tricky to get everybody through the study period. Next slide. But what we did find was some very significant results. So after PERT, diarrhea went from a score of 26 down to 8, which was very significant. Pancreatic pain also significantly reduced, as did bloating and gas. So the areas that we thought would kind of improve did, and it showed us that PERT really is quite worthwhile in our patients. Next slide. We then wanted to hear from people like yourselves what it was actually like to take PERT, because we're talking about lots of capsules and potentially a very burdensome treatment. And so we actually asked people in our region who are on PERT with pancreatic cancer what it was like. And so there were a few things that came out. One was that they had a really high understanding of their bodies and of the pancreas and of digestion, and they were able to titrate the medicine really well as long as they knew what it was for and what they were supposed to look for. So that was really great. They told us it changed their relationship with food, that they could go out and socialize, which they hadn't been able to do previously because of worries around diarrhea and finding toilets. And they also told us that it wasn't burdensome as long as they understood what it was for and that they actually got benefit. And so that was really reassuring to us, that we weren't pursuing research on something that was going to create burden for patients and families. Next slide. There's also quite a bit of evidence now that PERT is helpful, particularly in pancreatic cancer. There is in the cystic fibrosis space anyway. There's been some good randomized controlled trials there. And it shows that even potentially it improves survival. So we were in contact with a surgeon from Birmingham University in the UK, and he told us he felt it was just as effective as chemotherapy and surgery for some patients. So this is why it's really important we get this message out there. Next slide. nutrition. You want us to keep going, Stephanie? Are you happy?
Yes.
Hi, yes.
Yeah,
So
okay.
we'll keep going maybe and go just in the interest of time. We'll
Yeah.
get these last few slides in and then
Yeah.
we'll open it up to discussion. We'll do a thank you. And if there's anyone that also wants to stay on, if they didn't have their questions answered, we'll also allow that, if that's okay. Does that sound
Yeah,
like a
that's
plan?
fine. Yeah, no worries.
Wonderful.
Okay, so managing diet and nutrition in pancreatic cancer. One of the things we noticed right back at the beginning when we first started doing our studies was that patients were coming out being told that they had an intolerance to fat, and so they were restricting fat. So we say to our patients, do not restrict fat, eat as freely as you're able. There'll be some foods you don't feel like eating anymore, and that's fine, but try and keep the diet as broad as possible. Try to eat the most nourishing part of the meal first, meal and snack first, and try to have protein with each meal and snack. Next slide. And make use of the best time of the day. Usually when I talk to patients, they know what time of the day is best for them. It's either breakfast time, or some patients find they get up in the morning and it takes them a while to get going and it's around about lunchtime, and some patients it's tea time. But you focus on that best time of the day and fortify up that meal. And the other thing is people get fatigued, and it's a different type of fatigue that you get when you're well. It's a whole body fatigue. So it's really important to make use of convenience ready prepared foods, because if you spend 3/4 of an hour making a meal, you don't have the energy to eat the meal. So in the supermarkets and delicatessens now, there's lots of healthy, nutritious ready-made options. Make use of them. And manipulate your enzyme replacement dose depending on the fat content of the diet. Next slide. I often say to patients, with well people, we say sit at the table, eat your meal so that your brain acknowledges you're eating. But for palliative patients, that doesn't work. You're better off to use a distraction, because you'll eat more when there's a distraction like music, TV, company, then you're aware if you're sitting there trying to force each mouthful in yourself. Once you've got on top of the food aspect, then nutritional supplement drinks might be worth considering, and talk to your dietitian or doctor about those. Make sure you're getting variety in food so that you don't get food fatigue or flavour fatigue. And if you've previously been on a specific diet, it may be that you reprioritise and reset your priorities around what limitations you need to put on your diet. Now, we talked before about a Whipple's procedure. What exactly is a Whipple's procedure? And some of you will have had this. It's removal of the head of the pancreas, duodenum, gallbladder, lower bile duct, and sometimes a portion of the stomach, or a variation of that. Next slide. And initially after a Whipple's, you'll be encouraged to eat small frequent meals and save drinking to between meals so that you don't fill up on the liquid and then not get enough nutrition going in. Next slide. Monitor your weight and see a dietitian if you're losing weight. You may need to initially, just initially, avoid high fat meals after a Whipple's because you may not tolerate them, but progressively as your health improves, you'll get a wider range of foods going, and then you adjust your creon dose to what you're eating. Next slide. Now with chemotherapy, it's really important to maintain your weight because chemo is often weight to dose related. So if you suddenly had a big weight loss, they may have to adjust the dose of chemo they can give you. So it's really important to try and sustain that weight. And after 2 or 3 cycles of chemo, you'll get a good feel for how you are in the few days after chemo. And it might be initially you're fatigued and things, but then after that you pick up again. So you focus on building up your eating over those times. Next slide. You may also have taste alteration due to your chemotherapy, and it's worthwhile talking to your dietitian on strategies of how to alter that taste so that it tastes more appropriate. And fatigue is common, as I said before, so it's really important to make the most of the energy you do have. Next slide. If you're nauseated and you're taking nutritional supplement drinks, it might be worth holding those back while you get on top of the nausea, because if you keep drinking those through the nausea, you'll have that memory of those feeling sick with those drinks, and you may struggle to get back onto them again. Next slide. Loss of appetite, I always say to my patients, eat little and often. And with nausea, it's really important to try and eat little and often, because you can be nauseated with an empty stomach. Okay, make fluids count. So don't just drink water, have fluids that perhaps have a few more calories, and make the eating environment relaxed. And I always talk to families about not putting too much pressure on somebody to eat more, because it causes friction and then causes an unpleasant eating environment. Next slide. And the key point, next slide, key point is cancer affects people differently. And so if you're losing weight and you don't know what foods to eat, sometimes even the person caring for you, food becomes a bit tunnel vision because they've got so many other things to think about. Having a talk to your dietitian and getting some ideas can just open up those suggestions.
Okay, so coming to the end now. So we're part of ASPERT, which is a group across Australasia our mission statement is that everyone with pancreatic cancer in our countries gets access to PERT and a dietitian review. So that's how we've ended up here. We're on social media if you want to look us up. So yeah, next slide. And I guess one of the things we wondered about was, because this is so important and done so badly globally, is it time for an international position statement? Should we be as people who take PERT, clinicians who prescribe PERT, consumer groups that advocate for PERT, all be getting together and saying, look, this is just as important as other treatments, and can we raise the awareness across the world? So these are some of the things that we could put in an international position statement. A lot of clinical trials are done without standardization of PERT in our cancers, so it would be really nice to see that. And we have quite a big theme, new slide, on making sure all our studies involve our Indigenous people, and that all of our protocols and documentation improve equity across all of our different populations. So that they would need to be involved as well. Next slide, I think that's it. Questions? Only 5 minutes late, not too bad.
No, we did great. We covered a lot. So friends, we learned about pancreatic exocrine insufficiency and what that does to our body, and about the incredible importance. So whether you have cystic fibrosis and you're attending this session, whether you have pancreatic cancer or another disease that creates PEI, really over 80% of the patients diagnosed with these illnesses already have PEI. So that's why it's so important to ensure that you're receiving PERT. We also learned about the importance of PERT, and that PERT is just as important as the it should be a standard of care. It's not. It should be a standard of care, but even with pancreatic cancer, really this is life-changing in terms of quality of life and your access to treatment, because when you feel better and are better physically, you can obviously stay in treatment for a lot longer. And if you don't know how to take your PERT capsules, we've also given you a tool that you can register for at digestive.ca. Use that tool and help you learn how many capsules to take with your snacks and how many with your meals. It's a tool that has been created to round up. So you can always take a little less if you need it, but as Dr. Landers and Helen both stated, it's really important to err on the side of caution and take a little bit more, and then you can pull back after that. I'm going to do my whole thank yous, because I know we ran a little bit over, but if you've got questions and want to stay on, please do so. But I would like to thank both Dr. Landers and Helen Brown for being our wonderful guest speakers. And of course, I'd like to thank Viatris for making our national campaign and the PERT online calculator at digestive.ca possible. And now we've got questions. So please stay and listen to the questions if you have time, or ask questions. I hope that this was helpful to everyone that attended.
No, there's not. And the reason that omeprazole or pantoprazole is great, and I say to my patients, it's a good buddy drug for prion, is that we know your stomach sits at a pH of between 1 and 5, depending on what stage of digestion you're at. So that's acidic. And the reason the little beads inside your Creon capsules are enteric coated or protective coated is to protect them against the gastric acid. Now, when the beads get down to the capsule dissolves in the stomach, but the beads are still protected and they get into the duodenum, the optimum environment for that protective coating to come off is between 5.5 and 7. So it's gone from an acid environment in the stomach to suddenly, not much further down the track, a basic environment. So if you've got any acid overflow, or because you haven't got bicarbonate from the pancreas any longer coming into the duodenum may be sitting a little bit higher acidity level. And so by using omeprazole or pantoprazole or another PPI, you're ensuring that the duodenum is in the most optimal state to help the protective coating come off the enzymes and the enzymes be effective. So they're a really good buddy combination. So there's no worry with you taking one with the other. The other thing that I missed mentioning is that it's not recommended to take Mylanta or antacids or magnesium salts with Creon, because the Creon and the salts bind together, rendering both medications ineffective. So that's the only exception, but definitely your PPI and omeprazole is good to have with your Creon.
Yes,
Yes.
it does.
Yeah.
Yes, because that fat content, the fat doesn't get absorbed, and it's fat that causes the diarrhea.
Is it Creon 25,000? Just checking, because occasionally I've had patients that have had it prescribed through other sources other than myself. And when I check their dose, they've been inadvertently prescribed Creon 10,000. And you need to take that many more capsules to get a correct dose if you're on the lower dose. I very seldom prescribe Creon 10,000. The other thing being, if you're not taking enough and you're eating over the day, it will increase the frequency of bowel motion, because every time you eat, if you're not on sufficient, it will give you urgency. I think what I would do is I would work out your weight. If you get onto that Digest calculator, work out your maximum dose of Creon a day. And then as a baseline, I would be taking 2 to 3 with meals, and then 1 to 2 with snacks, depending on the content of your snacks, and just see what happens to your frequency, and monitor your bowel motions, because if your bowel motions are still pale, or they're floating, or they're explosive, it's going to be a bit of an indicator to you that you're not quite there yet as far as your dose goes.
That depends on the cause. I guess if someone had pancreatitis, where the pancreas is very inflamed or infected, and whatever reason that improved, you may be able to get some function. You actually have to lose quite a lot of the particular cells that make the digestion to get malabsorption. So it's not just kind of a little bit, it's quite a lot of the pancreas. So never say never in medicine. Those of us who work in palliative care have seen all sorts of things over the years, so we never say never. But if it's something like a blocked duct that's not going to be unblocked, you know, or scarring that's not going to be able to be removed, then no, you generally do have it lifelong.
It's generally the fat in food that causes the symptoms, but you need to be able to digest your protein and things as well. You have amylase in saliva, which helps break down your carbohydrates. So you actually start digesting your food in your mouth. But I think if you can work along with your dietitian, get her to work out what your maximum dose is, and then start yourself on 2 or 3 with every meal, and maybe 1 to 2 with every snack. If you have a meal that you know contains a bit more fat, the thing is, whenever you've had a time where you've had to limit something because of a health problem, it tends to rock your confidence a wee bit when you reintroduce that thing back into your diet. And that can be quite frightening, and you know, for somebody who has been having to avoid it for a period of time. So getting the support from your dietitian on what food should I first reintroduce back into my diet and work along beside you can help just boost your confidence a little bit.
I think what we've found is people are getting underdosed.
Yeah.
I don't think it's anyone's fault. There's not a lot of great kind of, evidence, if you like, but from all the people we've talked with across the world, it seems to be a problem that people are getting underdosed. And I guess one of our main messages is titrate it to your body. Once you know what your maximum dose is, you don't have to have that maximum dose. You just know that you've got room to move. And I think, everywhere I've gone and everyone I've talked to, it seems to be that people are underdosing. So please feel confident to try having a little bit more and use the PERT calculator. That will give you even more accuracy and feel confident.
There was a question about the cost of PERT, and we get that often. It's different from country to country. I was just talking to one of the team members at Viatris, and I'm going to put a link in the chat box. But the different manufacturers do have compassionate access. I know of patients in the States that have gotten 6 months support of PERT in Creon, and then they pay for the other 6 months, so that helps quite a bit. And then in Canada, we have drug navigators at the different cancer centers. So really accessing those drug navigators, that will also help you if it's not covered. I'm not really sure about the other countries, but starting with the manufacturer, they always have patient support lines, and that you can contact the manufacturer and directly talk to a patient representative there at the manufacturer that manufactures the PERT treatment. Is there any other questions that we can answer?
We got a question about a specific diet. It came directly to us, Stephanie. Just hopefully we've answered that in terms of there is no specific diet. We want you to live life.
Yeah.
We're really all about that. We want you to live.
Don't over restrict, because it makes eating more boring. And, in our day-to-day lives, a lot of our celebrations include food. And so by restricting your diet too much, it cuts you out of a lot of those important social things as well. My thing would be that variety is the key. Don't home in on any one food. Give yourself plenty of variety, so that, because the thing is, sometimes when you're going through treatments and things, you have taste alterations and things like that, and that impacts on your diet. So we don't want to add any unnecessary restrictions that are going to further decrease down your choice pool of foods that you can eat. So basically, your body will tell you that there'll be some things that you used to eat that just don't sit well with you now. And like Amanda says, listen to what your body's telling you, but generally don't over restrict.
What about things like seeds and, heavy sort of
the one thing I would
stringy,
going too high fiber will fill you up quicker, and will run the risk of perhaps you not getting enough protein and things like that in. So not taking anything to an extreme.
Moderation.
Yeah.